Good morning, good evening, everyone. Today we are going to talk about Ludwig's angina. Ludwig's angina is one of the life-threatening conditions in dentistry. First of all, we shall remind you that there are very many ways how bacteria or infection can spread from one place of the body to the other, or from one tissue of the body to the other. One, we said it can be through blood. From one place to the other through blood. It can be through lymphatic system, and can be through now what? Tissues. So now we are talking about the one where we can have infection spread through tissues at a fast rate. And one of them is this strangulating infection that was described in 1837 by Sir Wilhelm, and he described it as a strangling infection, and we can define it as an aggressive cellulitis. It is aggressive very quickly, aggressive inflammation of the floor of the mouth and under the tongue. It is aggressive, it can quickly spread. It doesn't need you to waste a lot of time. And we are saying it has three: sublingual, submandibular, and submental areas. Most of it is as a result of infection of the mandibular third molar or second molar. However, as you are going to see in etiology, it could be any other cause. But mandibular third molar, is one of the issues. Now, before we go into etiology, I will remind you something about anatomy. But what could be the cause of this infection? Now, the infection, last time we talked about how you should manage dental caries. We said in the enamel, we do not have pain. If we have any dental caries in the enamel, you should treat the dental caries in the enamel by change of behavior. If you don't change behavior, you could now do fluoridation, which could be through fluoride vanishes, through also what? Through fluoride vanishes, mouthwashes, or even fried gel, or any other source of fluoride. Sometimes you could even do cementing or conservation. If at all that is not done, the dental caries will continue to the dentine, where you have pain or sensitivity that disappears on removal of the stimuli. What do you do to that? Conservation. If at all it is not treated, it continues to the pulp, and you can have acute pulpitis and chronic pulpitis. So acute pulpitis, where we have pain which is spontaneous, that is not localized, that even a patient may not even know exactly where the tooth paining him, he or she is. It radiates the temporal region. It is not localized, it radiates the temporal region. Can you keep him awake? And sometimes we can move from there to chronic stage, where the tooth is necrotic, may or may not respond to painkillers. But now, if at all is not treated, still, of course, if it is pulpitis, we expect the treatment by either root canal, pulpectomy, or extraction. If at all those are not done, we go into abscesses. And we have different types of abscesses: periapical, which is most likely to come from the soft tissue injury, the soft tissue infection. But we have other types of abscesses we talked about in our previous videos. Which types of abscesses? We have gingival, where we said we do I and D. We also said we have periodontal, where we do scaling and polishing. We can do root planing and give, as we said, and give antibiotics, as we said. But now, we are saying, suppose it exceeds that level and we go to what? cellulitis. Cellulitis is an inflammation of the what? The connective tissue or the soft tissue, and could be both in the maxilla or mandible. But usually this condition we are going to talk about, Ludwig's angina, is usually in the mandibular areas, although it could also be in other areas, but usually it's mandibular areas due to dental infection, especially dental abscesses. Dental infection, it could be one of the what? The causes. Fractures, especially open fractures. Fractures which are open because you know the tone mucoplastrum, the oral mucosa is thin. So if it is a tone, it could expose saliva, to expose infection from the cutaneous tissue. It could expose pus or any skin infections, which could cause infection to what? To the body. We have osteomyelitis, we have tumors of the oral origin, and others. So we have the anatomy. I'm done with etiology. Anatomy. You know this one in black here, this is our mandible. And our mandible, you remember, we shall take a review on some of the spaces. We have this one as our myxoid bone. That means above the myxoid bone, we have what we call what? The sublingual space. Then below the hyoid bone, here we have the digastric muscle, the anterior and posterior belly of the hyoid muscle, and also this side. So in between there is where we have submandibular space, and in between the digastric muscle and the left and right, we have what? The sublingual space. Well, sorry, submental space. And the submental space is attached on the what? On the hyoid bone. So, this one is very as simple as this. So the sublingual, as I said, is above the myxoid what? Just above. So, just above the what? The myxoid muscles. So in case we have any dental infection, maybe, I'm beginning with this. If you have any dental infection, maybe, suppose this one, we say this is maybe a 37. A 37, there is easy communication between number one, of course, under in the 37, the one which is going to be affected is what? This one, the submandibular space. There is easy communication through the mandibular space, to the sublingual space in this left side, through the hyoid what? Muscle, the myxoid muscle. Myxoid muscle will quickly spread the infection from here to here. Then from the left, from the mandibular to the what? To the from the submandibular to the submandibular. It will easily move from 1 to 2 because there is easy communication from the submandibular space to the what? The sublingual space to the myxoid what? Muscle. Now, there is a very thin line, there is a very thin tissue from the sublingual space above the myxoid muscle of the right side and the left side. And therefore, since we have infection here, it quickly spreads to the right side of the sublingual space. And also, you remember, there is also a communication from the sublingual space here to the submandibular space through another what? Myxoid muscle. So also we shall have now what? Submandibular infection. Because here we have the anterior and posterior bellies of the digastric muscle. So we have now infection of all these areas. The remaining one is submental. Which one? Which will be the next what? Affected. When we are here, the masticatory space is also what? Affected. From there, the neck infection, the pharyngeal space will be affected as we move down to the what? To mediastinum. That is how the the infection will spread. And note that it is aggressive. And in our clinical feature, we shall say this one, it is aggressive inflammation or aggressive cellulitis, meaning the tissues, the inflammatory exudate inflammation is moving through these sublingual, submandibular, submental areas, and usually bilateral. It means this side, because the moment the infection reaches here, it will move through these spaces. Usually it is bilateral. The next cardinal clinical feature is that the tongue is going to be inflamed. It is going to be big, reddened, full of a lot of inflammatory exudate, and it will be big. It will no longer fit in the oral cavity, and therefore it will protrude out. So we have a swollen tongue which protrude out. Of course, the moment it protrudes out, we shall say it is elevated. The moment it will protrude out means we shall have easily drooling of what? Of saliva. We shall have easy drooling of what? Of saliva. So here we can have now drooling of saliva, which is a very common feature. Now, as the infection spreads, it is going to continue to affect the neck. The neck is going to be rigid, red neck. In some also books, you shall also in people, you shall feel there is a hard mass in the neck, non-fractulant. This is very important. The restricted neck or hard neck. And now another one, we have airway obstruction. Someone will not even be able to pronounce the words well. There is stridor. There is hoarseness of the voice. There is hardness in the neck, as you have said. Drooling of saliva, drooling of saliva. There is fever and what? And sepsemia. Fever. There is pus, although usually it is very minimal. Now there is also what? Tenderness. This happens quickly as a life-threatening what? Condition, but not it is bilateral inflammation of these what? Sublingual, submandibular, submental areas. The tongue is swollen, neck is restricted, there is hard mass in the neck, and there is proper movement which is not. Of course, there are other characteristics. For example, like you are unable to eat, you are unable to speak, you are unable to, and others. Of course, there is halitosis and other symptoms, but these ones would be the major ones. What can you do to someone who is having this emergency? You studied in first aid that these emergency situations should be handled as emergencies. Now, what do we do here? We have to create airway. The airway is created by what? Tracheostomy. Tracheostomy, we are creating a space. You are creating a pathway to the trachea. Then in a good setups, you can now pass what? Breathing tubes. But with the moment you create, you do tracheostomy, you are creating a way to the trachea, and it does hurt, causes some relief, and there is no strangulation. Because remember, our condition here, we are saying that Ludwig's angina, it is a strangulating infection. Antibiotic, as we said before, it will be good for you not to do this, to do culture sensitivity at this moment. You give empiric therapy, where you give treatment of antibiotics. Then you do what? Then you can do incision and drainage. After doing incision and drainage is when you now correct pus or exudate, and you take it for what? For culture and sensitivity. This should be done as fast as possible. How in incision and drainage, here you shall remember that we do blunt with what? With an instrument. You do blunt dissection, and you open into this what? open to this left side, one incision here on the right side of the submandibular space, another one submandibular space, also another one here at sublingual space, the other submental space. Then you can also create, as you do blunt dissection, you also create a way to reach this area. Until you also reach these areas, you make sure the pus is what? Is drained. Usually, practically, you can, it wouldn't be good to suture. Obviously, you cannot suture where you have what? Pus. You can leave draining, you put a draining outlet where pus will keep on flowing for maybe the next 2 or 3 days. The next day you review, you clean and put a fresh drainage. You clean, put enough drainage. As you're cleaning and you're doing incision and review, sometimes anesthesia may be a problem here, but you need to keep on draining. You remove this pus, you remove this all this exudate in this area. This one is very important. Sometimes if it is not too much threatening, you may not do this. But if there is airway obstruction and you think it may cause death anytime of a patient, you need to do it. But incision and drainage is key, because you shall get even culture and sensitivity sample in this stage. There is a common practice of many people leaving the painful tooth. If at all you remove the painful tooth, it's going to help you to also do more drainage through this extraction site. So extraction of the offending tooth is very, very important. Don't forget to give supportive treatment. You hydrate the patient, give normal saline in case, because this person has not been eating, give food, give all those treatments. Thank you so much. In case you find this video very important to you, kindly subscribe and share with the rest of the students. Thank you.